Great. Good evening and welcome, everyone. My name is Rich Carvajal. I'm a medical oncologist at the Northwell Health Cancer Institute, and I'm really thrilled to be hosting this outstanding panel of speakers tonight. I'd like to start off by thanking AIM at Melanoma and Save Your Skin Foundation in Canada for giving us this platform, and I'd like to thank you guys for spending some time. I know it's evening for many of you, so spending some time away from your family to talk about what I think is a really important topic. Before I start, let me introduce our panelists. At the upper left is Dr. Rapi Suan, who's an assistant professor of medicine at the MedStar Georgetown Cancer Institute, who's been working in the rare melanoma space for a number of years. On the upper right is Dr. Marcus Butler, who's an associate professor at Princess Margaret Cancer Center, clinical head of the immune monitoring team, and co-leader of the Immuno-Oncology Translational Research Initiative. And in the bottom left, Dr. Lutzky, who's a professor of medicine and the director of cutaneous oncology, director of the clinical trials unit at the University of Miami Sylvester Comprehensive Cancer Center. So what I wanted to do tonight was spend a few minutes talking about a new set of preventative clinical trials for patients with uveal melanoma. I would say I'd love this to be as interactive as possible. And so please throw in any questions in the Q&A as they come to mind, because I'd like to answer as many of those as possible. To maybe kick things off, I'll ask Dr. Butler just for his perspectives of where we've been in terms of how we manage patients with high-risk uveal melanoma in the past, and what has changed in the recent times that have led to this new generation of trials. Marcus?
Yeah, thanks. Well, there has been a lot of progress over the last decade, I think. 10, 15 years ago, there really wasn't anything that you could do for a patient. So they were monitored. They were sometimes found to have their eye diagnosed late because of awareness. And then you would do the treatment and tell the patient, well, call me if you start having symptoms because we don't have any options later on. Well, now we do have options for systemic therapy to try to help people live longer. And we're finding that patients who are found earlier seem to do better. So, or at least patients who have smaller tumors do better and on these treatments. So I think it's important to try to identify patients. So we now are monitoring patients more closely. And part of this also, we're learning that there are some subtypes of tumors that have higher risk for relapse than others, and therefore we can tailor the way we monitor these patients more closely. That also means that we can design trials for the patients at highest risk and get answers faster about whether the treatment will help them. And that's resulted in a really kind of an explosion of options of trials to try to give patients treatments to prevent relapse. There have been a lot of trials in the past, and the biggest challenge is there have been a lot of them that were negative. But probably that has to do with the fact our treatments weren't as effective, and also because we didn't really know who was going to relapse and who wasn't, or at least have a higher risk of relapsing in a shorter amount of time. Like one of the trials that we're really excited about is the darovasertib trial, which we've noticed in patients with metastatic disease that who also had tumors in their eyes, that we would see shrinkage of the tumors in their eyes. So there is a trial currently winding down that is giving patients this drug, darovasertib, to try to shrink the tumor before their eye treatment. And very soon there's going to be a randomized trial to see if we can shrink high-risk tumors and then for patients at high risk and shrink them to see whether we can reduce the amount of radiation or actually save their eyes, as well as monitor patients for relapse in the high-risk population.
Yeah.
So I think there's a lot of, and there are some other trials that we'll be discussing in a few minutes.
It's really a totally new paradigm to think about treating, giving some sort of medicine even before the eye is treated. I don't know, Susie, if you want to comment on that, the idea that neoadjuvant therapies may be even a more effective way to prevent recurrence than just doing adjuvant therapy?
So the neoadjuvant, I think ideas stem from the fact that, eye preservation is also important. But we have seen some signal from the idea already that there could be some signal going on in a neoadjuvant space. The more important question um, um, then or just as important question as eye preservation would be like would this neoadjuvant adjuvant treatment could prevent or delay the incidence of distant metastasis or improve their survival. That's, I think, to be seen from their initial signal. And I'm aware that part of the neoadjuvant study, at least the secondary endpoint, will also measure the PFS and OS.
Um, and I would say even in the neoadjuvant space, given what we've seen in cutaneous melanoma and other diseases where giving immunotherapy while there's tumor still in place is just more effective, apparently, in priming the immune system, preventing relapse. And so, Suthi, I was going to ask you a little bit later on in the program about the IPnivo trial in the adjuvant setting and how that was designed. And maybe now is a good time to talk a little bit about that. But I'd be curious if you think the next step would really just be replicating that design and doing it in the adjuvant setting, or do we think about maybe doing a little bit in the neoadjuvant setting?
That is always a challenge, Rich. And this is a really important question because, it depends on how we stratify the risk. In the high-risk space, are we using the LUMPO model, using the cytogenetics with clinical pathologic findings, or are we relying on the gene expression profile and the transcriptomic data? Because if you alter the tumor space, this question is something that nobody knows, that the GEP profiling might change, and you might need a new sets of data to like further stratify or define the high risk in this situation. But this is always really interesting. The um, in situ immune priming. We have learned from SWOG 1802 and Nadina that it has signal and it appears to or has a data that demonstrate like um, likely better results in the short term, although like the long-term data is going to be presented, I think, both at ESMO and like future um meeting.
So, Jose, one of the big advances that have been made is, I think, the strength of the models that are just getting better and better at replicating disease. And I think one of these models was used to identify HDAC4 as a potential target, which has led to your now open clinical trial of quisinistat. I think you might have some slides to share with the group. It might be good to share kind of the history of that, where you are with the trial.
Yes, thank you. Let me make sure I got the. Okay, you guys able to see this? So our challenge, as has been mentioned before, is to find out, where that person is among the universe of patients that have uveal melanoma, and I think that, whoops. I think that we now have some idea by doing this fine needle aspirations from the primary tumor, and we know that loss of this, the function of this gene called BAP1 is very important. Those are the patients that tend to relapse. We also know that the expression of this protein called PRAME is also very important. And we just recently had this very nice model that is really the only prospective data that we have from a very large group of patients, this gene expression profile that can really separate all these risk groups very well. So in Dr. Bill Harbor's lab here at the University of Miami, when he was here, he did a number of studies with drugs that would replicate the functions of BAP1. When BAP1 is lost, the cells cells do not differentiate, and he felt that this was very important in the genesis of the uveal melanoma. So he looked at human uveal melanoma cells, and there were BAP1 mutated with BAP1 loss and without BAP1 loss. And he looked through a number of compounds, like 5,000 compounds, and identified this drug, requisinus, that was able to prevent the growth of these tumors. If you look down here, these are the two BAP1 mutated lines, and this is the line that was unmutated. So there was no change here. But here, when you use this requisinus, that in this mouse model, there was marked reduction in the growth of these cells. So based on that, we decided to initiate a trial with this drug. This drug has been tested in phase 1 and phase 2 trials, and here we see the side effect profile. And what you want to look here is how many grade 1 and 2 and how many grade 3 and 4. And you can see that there isn't a whole lot of grade 3 and 4 toxicity. So the drug seems to be very safe. We picked this particular schedule here, which is the drug giving Monday, Wednesdays, and Fridays, because I think it's easier for the patients, and it seemed to have the better profile. So it very briefly, so this is an adjuvant trial. The way that we define the patient population here is patients have to have class 2 of this gene expression profile. At the time that the trial was written, we did not yet know about the importance of PRAME. So we selected patients that had a larger tumors that had a diameter greater than 12 millimeters, which really gives a very high risk group. So this group of patients at 3 years, 40% of these patients will have recurrence of the disease, will have metastatic disease. And the purpose of this trial is to lower that recurrence rate from 40% to 25%. So essentially, instead of having 60% of patients without recurrence, we want to have 75% without recurrence at 3 years. And that's how the trial was powered. So patients can be up to 6 months from the treatment of the primary tumor. And we're looking for 60 patients. We have 10 centers. This is not a randomized trial, it's a signal-seeking trial, but we're going to be using what's called a synthetic control arm. So, which means we're going to be taking the patients from the COOG trial that define those risk groups, over 1,500 patients, and try to match those patients with patients with the same characteristics in the trial. So it would give us some idea of whether this might be effective. We have actually started a trial at our center. We have 9 patients on the trial already. We are about to activate the other 9 centers. So I think we're going to accrue this very, very quickly. So I'm hopeful that we'll have a positive signal. These are the centers that are participating. It's us, University of Texas Southwestern, Duke, Stanford, the Angeles Clinic, Mass General, Dana-Farber, Northwestern, Georgetown, and Northwell. So I think we select the sites that cover a lot of the country, so patients will have access to this.
I think that's really important, Jose, right? Because access to these trials is so critical. And I think once upon a time, these trials were really only available at like a handful, a couple of centers. And so to have an adjuvant trial it's really available now on both coasts in the center of the country, I think that's really, really great.
Yeah, we're going to be looking at a lot of other characteristics with the samples we collect during the trial. We're going to be looking at metabolomics. We're going to see what the original metabolomics of the tumor is. We're going to see if it changes upon relapse. We want to see if the drug changes the metabolic profile of the tumor. So hopefully, even if it turns out to be a negative trial, we'll gather enough information that might give us a clue of why it did not work, or if it works, why it works in some patients and not in others.
It's going to work. Think positive.
I'm positive.
So this is an example, I think, of a trial that's stemming from really promising preclinical data. Suthi, I want to switch over to your IPivo trial. If maybe you wanted to share, a little bit about, what you found on the first trial, and what you thought of that, and what do you think the future is?
Right. So thank you, Rich. We have presented the data on adjuvant IPivo in high-risk uveal melanoma last year at the ASCO meeting and the oral session, the rapid oral session. The basis of this design was, although stage 4 uveal melanoma is not responsive to immunotherapy, the biology of the patient with a high risk is different because these tumors behave differently before it can establish the immune environment in the primary metastasis sites, mostly liver. And last year, we reported the 3-year distant metastasis-free survival in patients who received adjuvant Nivo in combination with IPI, who received it for about 48 weeks, that the 3-year DMFS or distant metastasis-free survival is about 70% as compared to the historical control from Cook 1 that was reported out in like 2012, that was 43.4. These are matched with the patient who has the high-risk gene expression profile with the size criteria that is 12 millimeter or higher. And this year, we will also present the data at the Society for Melanoma Research as an oral abstract on Monday on the final analysis of the 3-year distant metastasis-free survival and a long-term survival. What I can say now is the DMFS and OS has remained consistent with the earlier finding, which suggested that there could be some initial there could be the benefit that is sustaining over time. But I think the more important question that Dr. Lutzky just previously mentioned about is, recently we have Cook 2 data came out, and this somewhat changes the paradigm of how we define the high-risk uveal melanoma. At the time of study conception, which is in 2017, we started enrolling the patient in like early 2018, and the study took 7 years to mature. This Cook 2 data will become more relevant. Using the modern natural history cohort, the patient was classified based on GEP, PRAME status, also clinical pathological data with LUMPO, and then they follow with routine MRI. So when we compare the outcome with to the historical study that didn't have this level of risk refinement or sensitivity, we always introduce multiple bias, including both selection, late time bias, or information bias as well. So I think in many ways, the field are moving forward towards using the newer benchmark natural history as a more relevant benchmark than the Cook 1 that we use, but that does not define that the Cook 1 data is invalid. It just being looked into differently. So while we are encouraged to see this durability of our data, we also recognize that this is a signal finding study and a randomized validation needs to be done. And it is currently in the work through the Eastern Cooperative Oncology Group. And we have the designation of an EA6251 study, which still needs to be ironed out. Thank you.
Thanks, Suthi. Let me just ask, do you have Um, because I mean the findings were pretty striking, I think. I mean, that was a really significant improvement in outcome compared to historical controls. Um, so I'm pretty excited about the follow-up, but what's the timing, do you think, of like when might the ECOG trial actually be available for patients?
So this is a very, very important question, not to just us, but to the whole scientific community. The movement from the cooperative group study tends to be a little bit slower than either, investigator-initiated smaller signal finding cohort or industry-sponsored study. It took generally 2 or 3 years from the concept until the study is being rolled out, but that doesn't really mean that the question should not be answered. It still should be answered, and this might be the only way to answer the question. However, I think other clinical trials should also come up at the same time to help filling the space.
Mhm. Great, thanks, Sufi. So Marcus, as you know, I think the development of tebentafusp or Kimmtrak for patients who are HLA-A*02:01 positive with metastatic disease was, a really amazing advance for the field. And I think given the efficacy that was seen in patients with metastatic disease, I think it was a natural question as to whether it might be effective in the preventative setting. Do you want to talk about kind of where we are in the field in terms of answering that question?
Sure. So when we look at the clinical trials that resulted in FDA and Health Canada approval, patients with smaller lesions were tended to be in the groups that lived the longest and did the best, suggesting that perhaps treating patients earlier will result in better outcomes. And, that's the whole point of adjuvant therapy is that you're giving treatment after the eye is gone. So you're not treating the eye tumor anymore, you're treating microscopic lesions that are left behind. And tebentafusp is a drug which seems to work better in smaller tumors and there's no reason, in my opinion, that we should think that a microscopic dormant cell just kind of hanging out wouldn't be a target for tebentafusp. Some of these other treatments, the immune system sometimes really ignores some small deposits that are not really causing any trouble. So maybe, maybe IPvo won't work as well, and certainly Kimmtrak's easier therapy in terms of toxicity. And also the one could argue that some of the targeted therapies may not work as well in microscopic disease because the cells aren't active and dividing sometimes, they're dormant. So anyway, there are two trials that are happening now. One of them is the ATOM trial, which is a study where patients with high-risk disease are treated with tebentafusp for 6 months to try to prevent relapse. And the other trial is a trial that's available for both melanoma and uveal melanoma patients, where you can find, even on scans, which are completely fine, but there's circulating tumor DNA in the blood, suggesting that there might be some cells that are hiding out in the body that you can't identify, that we're going to see whether tebentafusp can be used to prevent relapse and make the ctDNA, the circulating tumor DNA in the blood go away.
Yeah. Yeah, thanks, Marcus. So the ATOM trial, that launched in Europe first, and was led by a group called the EURTC. So it's open in probably about a dozen sites now across Europe, Spain, Germany, Netherlands, Poland, and other countries. In the US, similar to Dr. Lutzky's trial, this trial will be open up at a number of centers across the US. So it'll be open up at a total of 8 sites in the US. And then Princess Margaret, Marcus, the plan is to have it open there, as well as possibly some other Canadian sites, depending on how things go.
Yeah.
And in terms of timing, we should have this open up at one or more sites by the end of the year. It'll open up at Northwell. Yeah, so we have scientific review. We signed one contract. I'm waiting on another contract, so it should be available soon.
That's great news.
So I'll just first of all I'll say if there are any questions, please put them in the chat. I want to answer all of your questions. But for the group, one thing we kind of touched on but didn't focus on is, how are we figuring, which patients are appropriate for these preventative trials? Suthi, you spent a lot of time talking about GEP, and Jose, you were talking about PRAME, and cytogenetics. Maybe it's worth spending a little bit of time about kind of what our thoughts are about what's the right patient population for these trials. And Suthi, yeah, why don't you go ahead?
Okay, so I think although the GEP rollout has been like relatively like homogeneous and universal in the US, I think the adoption is not universal in the globe. Like most of the UK and Europe still like relies on the cytogenetics and clinical pathologic data. That kind of underline the fact that not all patients who were like labeled or not labeled, identified as a high risk, have the same high risk feature. So that is something to be cognizant of when we interpret the data from different places. Yes.
Yeah.
I think the larger trial, though, there's going to be stratification according to the method used to define risk, right, Marcus?
Yeah, that's well the for the darovasertib neoadjuvant. So darovasertib trials. Right now, there's a neoadjuvant trial coming. There will be an adjuvant trial in the future. I mean, one of the things that I think the community has to wrap our heads around is that uveal melanoma can relapse late. We can prevent late relapses, perhaps. We don't really have a system which is designed very well to study that because it's extremely expensive to follow people for 10, 15 years. And for countries like Canada, where the label is really important, and also the way the trial is done is really important. If you study patients in just high risk patients who have a very high risk of relapsing in the first 5 years, it may exclude patients who have a risk of relapsing between years 5 and 10. So I think that's something in the medical community as well as the insurers are going to have to wrap their heads around. How do we prove that late relapse patients can be prevented in a way that's economical? Because these trials are so expensive. But when the trials that are coming out right now, since we want to have access and prove the concept that we can prevent relapse, this is going to include patients that are at very high risk. The class 2 patients, the monosomy 3, 8q gain patients. So that's a category of patients that are very high risk, but unfortunately, we still have patients dying who didn't have that diagnosis at the time they were diagnosed. It's just they relapsed later.
So I know we just have a couple of minutes left. We do have two questions in the chat. And so let me just run through these really quickly. One question is the blood test that scans for circulating tumor DNA, is it something that medical oncologists working in this field can order now routinely? Yeah, and I'll just take this. So this is in the US anyway, I think where we have the luxury of access to a lot of these tests. It is available, and there are a number of different vendors that can do this. So there are companies like Natera and Foundation Medicine, and a lot of these molecular genomics companies now can do these what we call liquid biopsies. So it's available. It's I think it can be useful information. I think as a field, we're still trying to figure out what's the right way to use this technology, though. The second question is, any trials for metastatic uveal melanoma when KIMMTRAK doesn't work? Big topic. And I think I might defer that to another webinar, unless Marcus want to.
The good news is that there are lots of trials now, so lots of potential choices.
Go knock on Dr. Lutzky's door.
That's right.
And
Well, Marcus, there's one for you too, because someone wants to know about darovasertib in Toronto.
Yeah, so unfortunately so what's happening with darovasertib around the world is that there are a few to answer the question about the KIMMTRAK, there are going to be a couple of slots at the sites in the US, but it's not those slots for the A2 positive patients will not be open in Australia or Canada. And then for the A2 negative study, they're not closed yet, but it's close to closing. So if you haven't, and it's only available for patients who've had no treatment. So I suspect we're going to have a period where we don't have access to the drug while we're waiting on the results of the study.
And to add to what Marcus and Jose mentioned, I think we will learn more next month at the SMR meeting when there will be the first reports of the overall survival data for the patient who received like crizotinib and darovasertib. We know that this disease control rate is 90%. We know that response rate is 50%. But I think the OS data would be very important and it could change the paradigm, not just the stage 4 area, but also could have some implication towards the early setting too.
Yeah. So guys, as expected, I think the time went by really, really fast. And I know there's some questions still in the chat. For the additional questions, I would recommend there's AIM's Ask a Medical Expert on their website. And I think Eric might be able to put that link in the chat. So please use that and speak to your provider. But I'd like to close by thanking our expert panelists and my friends and colleagues. This has been an amazing half hour. I'm sure the audience found this useful, and thank you guys for spending this time with us. So,
Your pleasure.
good night, guys.
Good to see you all. Bye-bye.
Bye-bye.